Thanks to the organizing committee, I managed to study morphology because my updates have to do with morphology, and it was a pleasure for me to study morphology because I realized that many clinical decisions are still based on morphology, so we all have to be accustomed and familiar with morphology. For example, a low-grade urothelial carcinoma non-invasive needs no intravesical therapy. It will be of no use. On the contrary, a high-grade non-invasive the patient will benefit from therapy. So other parameters like lymphovascular invasion and a presence, concurrent presence of carcinoma in situ, which cannot be described by molecular techniques, are very crucial. And as far as prognosis is concerned, when a patient receives neoadjuvant therapy, the single parameters which define his survival in the cystectomy specimen is the PTN pathologic stage and the margin, if the margin of the specimens are free. So we can understand from these examples that morphology is still valuable. So we'll try and have a talk on morphology, and of course we must remember some basic parts of the bladder anatomy. Here, the dome and the anterior wall. We must bear in mind that when we have a urachal adenocarcinoma, it should be located here in this area. It's something that invades the wall from the outside. So anatomy is what makes the diagnosis practically. Then this is an area which we should always pay attention if we have two specimens from this area, because in this area, that means where the ureters come and join the bladder, the cavity of the bladder, the muscle of the ureter, as it continues with the muscularis propria, is very thick. So in this area, if we have specimens, the lamina propria will be very, very short, and we'll have directly from the covering urothelium, we'll have the muscularis propria. So if one is a bit reluctant to diagnose a PT2 carcinoma and knows that the biopsies are taken from this area, he will feel more confident in diagnosing PT2 carcinoma. And anatomy has to do with another problem we often have is the muscularis mucosae, how thick it may appear, and it may confuse us in staging. If the biopsy is taken here from the dome, there is a possibility, if there is a female patient, that the muscularis mucosae is hypertrophic. Of course, there are other parameters as well, how many transurethral resections the patient has already had, because all these factors from the history make us think what we see under the microscope. So it's necessary to know the clinical history and where the biopsies are taken from, the two specimens. So we have the new classification. We use the term subtype for all specific morphological patterns of urothelial carcinoma, and not the term variant, because the term variant is kept only for molecular analysis. And there is a concept of having a whole examination of the organ and the tissues coming from the organ. That means it has to be correlated with cytology and with some recent radiological examinations which define the depth of invasion, and they promise to be very accurate. Something similar with what holds for prostate cancer with the Peerat's classification. So we have some rare entities with cancers deriving from small glands related to the urethra and divergent differentiation. This is something that, like the subtype, when we see it in the context of a urothelial carcinoma, we have always to define the subtype or the divergent differentiations. Either it can be squamous, adenocarcinoma, trophoblastic, Müllerian, and always report the percentage. either of the subtype or the differentiation. It's mandatory. So some terms are no longer valid, like urothelial hyperplasia and urothelial proliferation of unknown malignant potential, and they can be totally displaced or replaced by the term atypia. Of course, we have the molecular subtypes. It's not my context now. And the neuroendocrine tumors, I think we have already had the neuroendocrine tumors in the bladder. A very small percentage of a neuroendocrine carcinoma is of vital importance for the oncologist and should always be reported. And there is a proposal of defining the whole tumor as a neuroendocrine carcinoma, despite the fact that there may be a conventional urothelial component. And what we have to see is what is the more easy and practical way to subclassify T1 tumors. So here is the Müllerian differentiation, some ialinization. This is, if this is a pure pattern, it's a clear cell Müllerian adenocarcinoma. However, if we see a urothelial carcinoma combined with this differentiation, this is a divergent differentiation of Müllerian type, and it should be quantified. Here we have some microcysts and tubules. So if in the context of a conventional urothelial carcinoma, this could be the microcystic or tubular type. And here we have some signet ring-like cells. When we see such cells, we should always perform mucin stains because it is of vital importance if these cells go to the spectrum of an adenocarcinoma and thus are mucin positive, or if they are mucin negative, then they are in the same context as plasmacytoid carcinomas under condition that there is a diffuse infiltration of such cells. The covering urothelium, the lamina propria, and the muscle, the two layers of the muscle, they are not so clearly defined throughout all the anatomical parts of the bladder. So in cases we have to subclassify PT2 tumors, we better count if it is more than the half of the detrusor muscle or less than the half. We have the normal urothelium here. It's very important to know the umbrella cells and disregard any vacuolation or atypia which might be apparent here, and have a look how the normal urothelium has a very nice streaming and polarization with the ankles of the nuclei having a vertical orientation with regard to the surface. And this is very important to see the normal urothelium because in two papillary neoplasms we'll have the same picture as normal. Which are they? The papilloma, which has the same thickness as normal urothelium. However, we have branching papillae. And the other is papillary neoplasm of low malignant potential, which we have similar images to the normal urothelium, but in this entirety, which is retained in the recent classification of who, it's much, much thicker. So we should always have in mind how the normal urothelium looks like. And most importantly, to discriminate the low grade. What difference is the low grade carcinoma from this normal urothelium? And we should bear in mind that the subtle differences in the abnormalities of the low grade urothelial carcinoma, if encountered on a flat carcinoma, this is dysplasia. This is something interesting. Here is the wispy muscle fibers of muscularis mucosa, not always identifiable. If you want to be sure if you have detrusor muscle, you can make an immunohistochemical stain with smoothulin, but it should always be evaluated only with a strong internal positive control. And you see here, this is the detrusor muscle. However, in its border with the lamina propria, the staining is not so strong. So it's very ambiguous how specific this antibody is in discriminating the detrusor muscle from muscle elements of the lamina propria. We talked about the anatomical regions of the trigon, where the detrusor muscle is too close to the covering urothelium. And we have all these, the multiple resections which may justify a hypertrophy of muscularis mucosa. And as always, we have problems with crash artifacts, thermal artifacts, or necrosis. Now, let's start with rather smoothly contoured elements, quite superficially, like von Brunn nests, and with elements of inflammation, such as in cystitis, either cystica or glandularis, when we can recognize a layer of specific cells here above the lumen. So this is glandularis. Here we have an inverted papilloma with all these anastomosing cords, relatively of little thickness. And here we have a normal smooth contour. However, this is an urothelial carcinoma which involves von Brunn nests without invasion. So we always look at the covering urothelium. And here is a high-grade in situ carcinoma. You see the other mucosa here is denuded, but there are some remaining high-grade cells. And you see that the von Brunn nests can be involved by the in situ carcinoma and retain their smooth contour. Now here we have something different, and we are lucky enough because we can see all these coalescence of all these nests. So we cannot say that this is a reactive lesion or a proliferative lesion. Despite its blunt cytological morphology, this is a specific subtype of carcinoma, the nested subtype of invasive carcinoma. All subtypes of urothelial carcinoma are considered high-grade lesions, no matter how blunt their morphology may appear. And here we have an infiltrating pattern which is inconsistent with cystitis glandularis, and some tubular formation which is compatible with the microcystic carcinoma. And as always, we should always look for the conventional urothelial carcinoma so that we define all that we see as subtypes and not other types of carcinoma. Have a look here at florid von Brunn nests, and by contrast, the nested subtype of carcinoma. Cytology is blunt, however, we should always pay attention to the deeper part of the tumor, because this is where invasion occurs, and this is where we have all this mixture, all this coalescence of the nests. So we should always look at the deeper part and see there if there is atypia, perhaps increased mitosis, perhaps fibroblastic reaction, and specific signs of invasion, so that we do not miss the nested subtype. In contrast, when we have just florid von Brunn nests, we have a linear configuration, and of course it has nothing to do with detrusor muscle. Anything we see in the detrusor muscle is invasion, with a very small exception if it is a diverticulum. That's something different, we should know that. Here we have larger nests of blood cells with some minimal fibroblastic reaction, generally smooth contour with some signs of angles here, and we are fortunate enough that the biopsy has taken a significant part of the muscularis propria, and we see these blunt appearing nests clearly invading the muscularis mucosa. So this is a nested subtype of urothelial carcinoma, which is always invasive. And here it can be staged as PT2. So what we mean by invasion, we have the problem when we have regular contours. We are still in stage PTA. We always look for a superficial exophytic component. And accordingly, we sometimes have to tell if these are papillae cut transversally. So we are never sure if we see something in the lamina propria, whether it's a matter of cutting what we see that is in the lamina propria, or is a genuine inverted pattern. Here, where there is no invasion, non-invasive lesions, here we have all these tubules. It's the tubular subtype. However, here we have clearly signs of urothelial cells. And to my mind, these are not true glands. This is not true glandular differentiation. This is gland-like structures. So I'm not sure we can define a specific subtype of urothelial cancer based on this image. On the contrary, this image helps us to define the subtype of tubular carcinoma under condition that somewhere else we have also seen conventional urothelial carcinoma. Because in other case, we should think of an adenocarcinoma based on this morphology. So here we have non-urothelial neoplasm. Here is a not otherwise specified adenocarcinoma with desmosplastic reaction. This one, it has papillae. However, it looks like an urothelial carcinoma because, however, there are glands and highly pleomorphic cells with brisk mitotic activity. This is a Mullerian clear cell adenocarcinoma. If we have the same image in context with a conventional urothelial carcinoma, this would be Mullerian divergent differentiation. Here we have another type of carcinoma, of adenocarcinoma with signet ring cells, which are mucin positive. So they do not belong to the urothelial carcinoma subtypes. And here we have an adenoma of intestinal type, as we all are familiar with this, and non-invasive, at least in this field. The urachal, this is a carcinoma which can have a diverse morphology of adenocarcinoma. However, the most significant is to realize that it's something from the outside involving the bladder wall. And of course, it can be invasive. If we find some remnants, some urachal remnants, it would be of help, but it's not necessary. Always the anatomic location is the key to diagnose the urachal type of adenocarcinoma. This is what I misjudged. Fortunately, I had a case of papillary urothelial carcinoma, which was conventional, as we all know it. However, there were some specimens like this, and I considered them as part of the tumor. They aren't. This is not urothelial carcinoma. These are not true stalks. They are too delicate. And if you see between the papillae-like structures, you have hyperplastic urothelium, like here. This is a tented pattern of urothelial atypia. So when you see this configuration, don't diagnose a papillary urothelial carcinoma, because this most probably represents a shoulder lesion. That means we have the tumor, and adjacent we have these papillae-like structures. You can use the term atypical urothelial proliferation, either flat or tented. But these are not true papillae. Of course, these are not true papillae either, because they are too broad, no matter how narrow they come here on their bases, and there is an increased inflammatory infiltrate, which helps us to diagnose papillary or polypoid cystitis. And it's most helpful that these papillae-like structures, like the previous one, do not branch between them. They are separate. Most papillary urothelial neoplasms have branching papillae. There is no branching in these two entities. And of course, here we have some thin papillae lined by cells with a bit of hobnail appearance here in the tubular compartment, and we have some sort of reactive stroma, so we do not miss some sort of metaplasia. What metaplasia is this, and how can we further confirm its presence? I want somebody to talk, because if I talk too much, I'm afraid they'll all leave. So let's have a bit of chat, because it will help us be interactive. You want me to show the stain? Here it is. So it's nephrogenic metaplasia, all right? It can be papillary. Always look at the stroma when you have a suspicious lesion, because it might be reactive. Always take clinical information, whether there has been radiation to the patients or intravesical therapy, and not diagnose these as malignant. And the same holds for the atypical cells, which could be degenerative due to the therapies that have been implemented in the bladder. You see, now what we said here, there is a nice, this is flat. This is a papillary, non-invasive, low grade. You can see some hyperchromatic cells damaging the orientation. Have a look how they look. Most of them look properly oriented. However, there are some of them that aren't, like this one here. Have a look at the axis. So this is like a low-grade, non-invasive papillary carcinoma, but we see on flat epithelium. So this is dysplasia, and of course, we can use cytokeratin 20, P53, and possibly CD44. However, that would be the urothelial dysplasia is a precursor lesion to the high-grade intraurothelial neoplasia, which is in situ carcinoma, which can leave many few atypical cells on the surface, and most part of it can be exfoliated, or it can show a pagetoid spread, and this will be very difficult to discriminate in immunohistochemistry, because the other urothelium will be normal. So we'll have a specific staining of cytokeratin 20 only in the pagetoid cells, cancerous cells. This is atypia. We see the inflammatory cells. This is in situ carcinoma, increased nuclear atypia. A papilloma, you see, it's like normal urothelium, but there are papillae which branch, and some of them seem to float free as they are cut. So this is the classic carcinoma, urothelial papilloma. This is an inverted one with thin cords, anastomosing, and no superficial component. And here are the diagnostic features. Now, low grade and high grade, we said at the beginning how important it is to discriminate. Here, we have a totally normal polarization of the urothelium. However, it's of increased thickness, and this is papillary urothelial neoplasm of low malignant potential. Here we have some degree, have a look here, some degree of architectural disorders and clear papillae, no invasion. This is low grade. And here we have more atypia, mitosis in upper parts away from the basal compartment. So this is high grade, and when we have both, because grade heterogeneity can be a problem, we must count the high grade component. If it is more than 5% of the whole tumor, this is classified as a high grade urothelial carcinoma. If it is less than 5%, this compartment of high grade morphology, then we say it is a low grade with focal areas of high grade, less than 5% of the whole tumor. See how nice the cells go up, the streaming, and increased thickness and branching. This is a papillary urothelial neoplasm of low malignant potential. Could this be an inverted papilloma? We can see the palisading of basaloid cells. However, we see a significant exophytic compartment which is incompatible with the diagnosis of an inverted papilloma. So this looks like a papillary urothelial neoplasm of low malignant potential with a significant endophytic or predominant endophytic component. Here we have low-grade cancer. See that there is architecturally, there is mild distortion of the architecture. And of course, here we see fused papillae, not just branched, fused papillae. So this is compatible with high-grade, taking into account the high-grade cytology. Here is what is required and recommended to be reported. You can have a look at the notes. Stage and grade, the most effective predictors of BCG response. So morphology has a lot to say still. And always we have to look for an in situ component and describe its presence, either if it is extensive or focal, and always look for a neuroendocrine compartment. And whenever we have a subtype or divergent differentiation, we should quantify. Here is something that molecular techniques cannot define. It's lymphovascular invasion. And of course, we have in mind that this is not a micropapillary subtype. It is true lymphovascular invasion, and we can perform immunohistochemical stains, possibly with antibody against D240, to see that there are endothelial cells. These are endothelial cells. So it's very important. And now let's have a look at the staging. We'll separately talk how to substage PT1, and here we have in radical cystectomy specimens T2A and T2B, according the depth of the detrusor muscle being invaded, and PT3. There is some difficulty in diagnosing PT3, that means extension in adipose tissue, because often the border is not so clear where the detrusor muscle ends and the adipose tissue starts, especially if there is desmoplastic reaction to the tumor. So we have to take deeper sections sometimes, and here we are lucky because we have the vascular plexus where the muscularis mucosa is located, and in this case we can judge whether the invasive cells in the lamina propria are before, within, or beyond the muscularis mucosa. It's not always possible. Here we have patterns of invasion, clearly invasive. Here are the wisps of muscularis mucosa being invaded, and here are the thick bundles of detrusor muscle being invaded by cancer cells. So, which is the easiest way to subclassify PT1 tumors? This is an invasive group of urothelial cancer cells which does not exceed a high power field. All we see, the invasion is here. So this is T1 microscopic. If the invasive cells are constricted within one high power field, we diagnose T1 microscopic. If it's more than one high power field, we diagnose T1 extensive. However, we should make some clarification how extensive it is. Is it just more than one high power field, but less than a 20 power field, 200 magnification? Is it in many places? Is it multifocal? Is the invasion multifocal? So apart from diagnosing PT2 extensive, we have to make a comment if it is in one focus or multifocal, so that the clinician knows the extent of the lamina propria invasion. Of course, there are other systems in micrometers and in relation to where muscularity mucosa is, but they are not easily reproducible. Here we have macroscopic infiltration in perivesical fat, so it's T3A. That's what we said about the border where the detrusor muscle, the muscularis propria, ends and where the cancer cells invade the adipose tissue. It's not always easy to define. We have deeper sections. We have to take deeper sections. Here is clear invasion of fat tissue with a perineural invasion of dubious significance. And of course, we have to take into account if we have the plasmacytoid subtype. I won't talk much on subtypes because there is a separate talk on subtypes. But the two important subtypes is the micropapillary, because it's highly aggressive. So even if we have a T1 urothelial micropapillary subtype carcinoma, perhaps the clinician would suggest to make a cystectomy, even if it's PT1. And here, if we have a plasmacytoid with a diffuse infiltration of plasmacytoid or signet ring cells without mucin, then we must be very careful examining the margins, because this subtype very often has positive margins. And if we know that from a biopsy, the urologist may send frozen sections from the ureters. That means the margins of the ureters to be examined microscopically, because if it's a plasmacytoid urothelial carcinoma, it might be positive. The ureter margins might be positive. And of course, we have extension to the prostate. Here is a prostate biopsy. However, we see these nests of pleomorphic cells, something not so often in prostate. And this is PT4. However, this is not PT4 of urothelial carcinoma, because here we see that the urothelial cells, highly malignant, have spread intraepithelially to prostate ducts and axilla. And here we are lucky enough because we can see the remaining acinar cells of the prostate gland, which are safe. Anyway, we have our immunohistochemical stains to define the presence of basal cells, so that is not invasion, and to see the origin of the tumor, if it's urothelial or is NKX31 positive, that means it's prostate cancer. In that case, this is staged as urethral carcinoma, not bladder carcinoma. This is staged as urethral carcinoma. And this may be very extensive. I had a specimen where this intraepithelial spread of urothelial carcinoma was extended to the seminal vesicles throughout the periurethral prostatic ducts, the axini, and intraepithelially always in the seminal vesicles. Perhaps we had it together, I think, if I remember well. And we have the divergent differentiation. Always quantify the percentage, squamous, frankly adenocarcinomatous, trophoblastic. We need some immunohistochemical verification, because if we see cells, they might look like sanctiotrophoblasts, but they are not always so. And on the contrary, the patient can have high-level serological of human chorionic gonadotropin without any syncytiotrophoblastic cells. And of course, we have the neuroendocrine component, which is of crucial importance to be defined, here of the small cell type. That's the same here, trophoblastic divergent differentiation with these cells. It could be syncytotrophoblasts and cytotrophoblasts. So we perform the human chorionic gonadotropin immunostain, and of course, we define the urothelial differentiation by GATA3, which, by the way, can be diminished, reduced to a very large extent in high-grade urothelial carcinomas. The micropapillary, we talked how aggressive it is. And here we have the plasmacytoid with some cells diffusely infiltrating throughout the bladder wall, and perhaps some of them have signet ring morphology without mucin. So it's urothelial carcinoma. Patterns of divergent differentiation, squamous, neuroendocrine, plasmacytoid, and micropapillary. And sarcomatoid, the best epithelial marker to look for positivity is high molecular weight cytokeratin. It is most often expressed in such sarcomatoid subtypes of urothelial carcinoma, and so it defines the urothelial nature of the tumor and the epithelial nature of the tumor. The key points, I think I will find. So, the three categories, papillary urothelial neoplasia of low malignant potential, and papillary non-invasive, low-grade and high-grade. We must be very familiar to diagnose these categories. The heterogeneity, the crucial amount of 5% to define the grade of the tumor, the substaging of T1 tumors, the one high power field of invasive growth, less or more, and in case it's more, mention how extensive it is by the multifocal invasion. Always look for lymphovascular invasion and concomitant presence of carcinoma in situ, and say if it is abundant in one focus or multifocal. For any subtypes or divergent differentiation, the presence and percentage should be reported and always have strict clinicopathologic correlation to diagnose an urachal carcinoma. So those were my key points, and now this is my take-home message, because I have one take-home message for the last slide. That's my take-home message. Thank you very much. And on time.
And of course on time.
Of course.
We enjoyed it very much. It was highly educational. And I would like to thank you very much for this. And to the audience now, have you any questions about on the field?
Either it was too clear or too obscure.
Yeah.
One of
There is one
yes.
question.
Hi.
TNM system tells us that the infiltration in T1 is of suburothelial
Lamina propria.
connective tissue.
Yes.
So this was my question to myself. It's not an anatomical part of the subconnective tissue. So
No, there is no submucosa in the bladder. No submucosa. Lamina propria.
Lamina propria. But we identified the suburothelial connective tissue with the lamina propria. So
It's the same.
okay.
It's the same.
It's the same. And when you find those little muscle fascicles coming from, because I found I'm revising a lot of cases where some colleagues wrote that there was a focal infiltration of tiny muscular fibers. And this was interpreted as a muscular invasive cancer. And the patient went to cystectomy and was quite
Limited. It was limited.
Yeah. Because it was on
If we,
but also because there was nothing left. There was no cancer, no
I see.
basic cancer.
There is a case where there is invasion if we have the two specimens and you see small parts of muscle fibers being invaded by cancer cells throughout the specimen, throughout, not just in one place. You can have a Mason trichrome stain or a Desmin stain. If you see muscle fibers throughout the whole tissue fragment being invaded, this is a sign that it could be T2. Because sometimes the invasion is so thorough that the thick bundles of muscularis propria no longer appear as thick. But this is not so often, fortunately.
It's
And also, you shouldn't diagnose muscle invasive. You have to mention which muscle you are meaning. Is it the detractor muscle or the muscularis mucosa? You have to be very specific.
It's a sort of miscommunication with clinicians because I believe that my colleague intended that there was a little fiber of the muscularis mucosa, but it was intended as a muscle invasive cancer. So it was considered a T2 instead a T1.
You can ask from the history if there were multiple resections, transurethral resection, because if it has been cystoscopically examined and biopsied more than 3-4 times, then this causes hypertrophy of muscularis mucosa. You can bear this in mind as well.
Is there any other question? Because I have one. So it's a practical question. When you have a high-grade papillary carcinoma, invasive or non-invasive, that's not the question, and you see flat areas with carcinoma in situ, do you diagnose it as carcinoma in situ, or is it as a shoulder lesion? Because it can be a shoulder lesion, like in low-grade.
High-grade flat lesions, they are always diagnosed as in situ carcinomas. If it is low-grade, it could be a shoulder lesion.
That is what I do, but I have read that some people, when they see a papillary carcinoma, they don't diagnose carcinoma in situ because they consider it as shoulder lesion.
No,
I also do that.
The presence of carcinoma in situ should be reported, and it's of crucial importance for the patient.
So if you see flat lesion,
it's not part of the lesion. No, it's separate.
Okay, thank you.